So good morning. It's a pleasure to be here today to present the results of our study on the validation of the Canadian TIAA Score. I have no conflicts of interest to declare. I'd like to acknowledge my co-investigators, many of whom are here today, and as well as funding by the Canadian Institutes of Health Research. So transient ischemic attack, or TIA, precedes approximately 15 to 20% of all strokes. Hence, this is an opportunity for preventative interventions to improve outcomes and decrease mortality. Existing scores have performed poorly when validated after they've been created. As a result, our group has previously derived the Canadian TIAA score in a prospective cohort of 3,900 patients at 8 sites. Previous studies of emergency department TIAA patients has shown that approximately 10% will have a subsequent stroke within 90 days, half of which happened within about 48 hours, but you can see that the curve is still very steep until approximately 7 days, at which time it starts to plateau. Previous studies have also shown that when carotid revascularization is performed for patients for whom large vessel disease is the cause, this is best done early, ideally within 2 weeks, where the NNT is about 3 for those with 70 to 99% stenosis. So who's at high risk? Our group has previously conducted a prospective validation of the ABCD2 Score, probably the best known risk tool currently available. And in this prospective study of over 2,000 patients, we found that the sensitivity and specificity at the different cut points suggested was actually quite low and not strong enough to be used reliably. As a result, we continued on to prospectively derive the Canadian TIAA score, and this was published in 2014 in a cohort of 3,900 patients. So the Canadian TIAA score includes 9 clinical features, which vary in points from -3 for vertigo to +3, as well as 4 variables that rely on investigations, for a total score between -3 to 23. So the objective of this study was to prospectively validate the Canadian TIAA score in a new cohort of emergency department patients with TIA or non-disabling stroke. So this was a prospective cohort study conducted at 14 high-volume urban Canadian emergency departments over a 4-year period, including both academic and community hospitals. We enrolled consecutive emergency department patients with an ED diagnosis of TIA or non-disabling stroke. We excluded patients if they had symptoms for greater than 24 hours, if they had a clear stroke mimic as their final diagnosis, or they were administered TPA as part of a stroke code protocol. Physicians completed our data collection forms, including the Canadian TIAA score and all of its individual elements. Our research staff collected results on investigations, admissions, consultations. Our outcome was subsequent stroke or carotid revascularization, so either carotid endarterectomy or stent, within 7 days. So for these patients, we conducted 7 and 90-day telephone follow-up, including a previously validated tool, the Verifying Stroke-Free Survival questionnaire, as well as reviewing all available medical records. Any patient with a possible subsequent event was adjudicated by a local stroke adjudication panel comprised of 2 stroke neurologists and 1 emergency physician, generally per site, to assess the case, and they're blinded to what the Canadian TIAA score and the complete records of the initial emergency visit when adjudicating the subsequent events. Our analysis included descriptive statistics, univariate analysis, and calculating the interval likelihood ratio with the corresponding 95% confidence bands, as well as the probability of a subsequent stroke or carotid revascularization within 7 days. Our estimated sample size was 5,004 patients, including 93 patients with a subsequent stroke within a week. This is what our data collection form looked like. So of 9,398 eligible patients, 7,569, or 81%, were enrolled in the study. There were 1,829 patients who were missed. These patients had similar characteristics as those involved, and we feel were missed because of the busyness of the emergency departments rather than some systematic selection bias. And of the enrolled patients, just 8 patients did not have some form of follow-up, whether it be the telephone follow-up or subsequent health visits at our institutions for which we could ascertain what their follow-up status was. And of these enrolled patients, 181 had a subsequent stroke or early revascularization within 7 days. 107 of these were subsequent strokes, and 74 were early carotid revascularization procedures. So this corresponds to an event rate of about 2.4% within a week, and this increased to 4.3% over 90 days. So this is the univariate analysis. I don't know if you can see, the screens are a little small from the back, but essentially the second last column is the group with a positive outcome within a week. So we found here the typical offenders, so weakness, whether it be face, arm, leg, pronator drift, or the composite of them, they're all statistically significant for having a subsequent event. Any speech difficulty as a composite, but in particular dysarthria individually, was significant, as was systolic blood pressure and CT findings of acute infarct, old infarct, or any infarct, as well as if the patient was already on aspirin at the time of the first presentation. So this is the main results slide. So essentially here we found that low-risk patients, so those with a Canadian TIAA score of -3 to 3, these patients had an interval likelihood ratio of just 0.2 for a subsequent event within 7 days, or when calculating the probability, this resulted in a probability of less than 0.2% of having a subsequent stroke or early revascularization within 7 days. When looking at the medium risk group, so this is a TIAA score of 4 to 7, these patients had an interval likelihood ratio of 0.8 and a corresponding probability of 1.3. And the high risk group, so patients with a score of 8 or higher, remember the score goes from -3 up to 23, so anyone with a score of 8 or higher was deemed high risk. They had an interval likelihood ratio of 2.2 with a corresponding probability of 2.6%. So the Canadian TIAA score accurately identified emergency TIAA patients' risk for subsequent stroke or revascularization within 7 days. We believe that low-risk patients can be safely discharged following a careful emergency department assessment with routine follow-up. Moderate-risk patients should undergo additional testing in the emergency department, so neck, head, ECG at the bare minimum, have antithrombotic therapy optimized, so anticoagulation for atrial fibrillation, single or dual antiplatelets, depending on what the case may be, and have early specialist follow-up. And high-risk patients should be fully investigated and managed in consultation with their stroke specialist during their indexed emergency department visit. So some limitations, well, this was an observational study where there is some variation between treating physicians and between different centers regarding testing and management. We have not yet adjudicated the side of the carotid intervention to make sure that it corresponds to the side of the symptoms. However, intuitively, the specialist should only be intervening when it's appropriate to do so, which would mean that it did correlate. We have not yet completed the refinement step. So as part of clinical decision rules or prediction score methodology, you should try to refine your tool during the validation phase to either get better sensitivity, better specificity sensitivity, or make it a less complex model. So we are still working on that. And finally, unlike other emergency conditions, the Canadian TIAA score will not give a 100% sensitive model which directs care, but rather one that identifies a high, moderate, and low-risk patient group for which individual physicians or their hospitals can determine what is the best management course for that level of risk. So in conclusion, we have successfully validated the Canadian TIAA score to identify patients for subsequent stroke or carotid revascularization within 7 days, and it is anticipated that the Canadian TIAA score will optimize resources to ensure maximum investigations and therapies are directed at those patients at highest risk of a subsequent early stroke. I'd like to thank the site neurologists who spent a lot of time adjudicating our outcomes, to all our physicians, nurses, residents who completed our data collection forms at all of our 14 sites, our research assistants and nurses at all the individual sites and the coordinating center, and a special call out to Angela, Jane, Connor, and Mary Jo, who were instrumental to completing this study. Thank you very much. I'll be happy to answer any questions.
Thank you, Dr. Perry, for your excellent presentation. The abstract is open for questions. If you can please come to the mic and introduce yourself with your name and institution prior to asking your question.
Hi, Brian Heaston, Wake Forest University. Thank you for this work. I'm really glad to have something to push back against the use of the ABCD score. Question, is this a natural history study, or are the patients that are in this cohort, did they undergo interventions? Did they undergo anticoagulation? Did they start antiplatelet therapy? And we're seeing this level of risk despite interventions designed to prevent recurrent stroke. Thank you.
Great, thank you for the question. So this is a prospective cohort study, so patients were being managed, and the management did include anticoagulation, controlled blood pressure, control of lipids, revascularization when appropriate. So certainly it did already look at that, and that would be the main reason why, if you saw the percent of events, it was 2.4 going up to 4.5% kind of thing, and that's much lower than the historic 10.5% that you see by 90 days. So yes, it does take that into consideration, but many patients are still not being managed fast enough such that they have a subsequent event before all the interventions are done.
And the next question.
Hi, Bernard Chang from Columbia University. Thanks again for a really awesome talk. One of the questions I have for you is with regards to our collaborations with stroke neurologists. Oftentimes they'll say the really big challenge with discharging some of these patients safely is that you worry about any symptomatic extra intracranial stenosis. So factoring this into your model, do you see any value then in type of vessel imaging prior to sending these folks home, or how do you think about with imaging?
Yeah, so I believe there definitely is a role for imaging vessels, especially anybody who's at moderate or high risk. I definitely would advocate for imaging vessels in those patients while they're in the emerge. However, the low-risk group, I conversely would say that they don't need this done because they are at a very, very low risk for a subsequent event and can be managed much more routinely rather than using a lot of intensive resources and valuable stretcher space in the emergency department.
Great, and we have time for just one more question.
Hello, thank you for a very well done study. My name is Jens Fretborn. I'm a resident in Sweden from Linköping University Hospital. I have a short question about the numbers because, as I understand it, the prevalence in the whole population at 7 days for stroke or revascularization was 2.3%.
2.4, yeah.
2.4, sorry. And the high-risk probability in the high-risk group was 2.4% for the same numbers. So I have a hard time understanding how the highest risk was not even higher than the base prevalence of the whole group. Can you allude a little bit more to that?
Yeah, so I mean, it certainly varies depending on what level of risk there are. We have looked at, kind of looking at here where you look at the highest risk, and it does suddenly go up much higher and sort of present by the level. So with the overall statistic, it sort of only gives the 2.2, but as you go higher and higher and you get patients at higher risk, it does increase.
Thank you, Dr. Perry.